Welcome, Dr. Hofmeister. We're getting questions saying, where are all the different places that he's been? And he could really...
Which stone have I crawled out from under? That's oftentimes the question that I get. That sounds very appropriate. Well, hi everyone. How's it going?
Yeah, welcome. Well, I'll give you a proper introduction, but we were waiting. They said, wait, I said, Dr. Hofmeister's from Emory. And they said, well, wait, I think he had spent some time at Ohio State. So
right. I don't know the criminal equivalent, but yes, I was at Ohio State for, about 10 years. And before that, had all my training at Loyola on the west side of Chicago.
Oh, okay. Well, and I do have a proper introduction, and we're just getting people joining, and I'm so grateful to have Dr. Hofmeister with us. And I'll go ahead and share my screen and we'll get started. Want to start with a big thanks to our sponsors, Bristol Myers Squibb, GSK, AbbVie, and Takeda. And also wanted to let everyone know that this meeting is being recorded. Here we go. So grateful to have our guest of honor here, Dr. Craig Hofmeister. So I'll take my hand at introducing, and if I miss anything, Dr. Hofmeister, you can help me out. So Dr. Hofmeister is the Associate Professor of the Department of Hematology and Medical Oncology at Emory University School of Medicine. He's board certified in internal medicine and hematology. His practice focuses on plasma cell cancers, including plasmacytomas, multiple myeloma, and amyloidosis. He joined Emory in 2018. His research focus is on early drug development and investigator-initiated clinical trials, exploring novel diagnostic treatments. And as a translator researcher, he's been funded continuously from the National Cancer Institute since 2016, which I thought was very impressive. And it really is my privilege to introduce you. And we're so grateful to have you here. And Dr. Hofmeister is a great supporter of the foundation. And we're so grateful for that and grateful for him.
Can you close the back for me, please?
So a few housekeeping things. If you can go ahead and mute yourselves, that will be great, and we'll get rid of the background, and that way we can focus on Dr. Hofmeister. I'll stop sharing to allow you to share, Dr. Hofmeister, and the time is yours.
Okay, hi everyone. Very nice to see you. Thank you so much for taking time out. Some of you are mobile in your car. Some of you are at home, at work, wherever. So I know you're busy, and I'm looking forward to chatting with you. So the topic that I was given to chat with you about is recognizing signs of relapse and how to talk to your doctor about it. That's the name of the talk that I was asked to give. And so I have a few slides that I thought we'd chat about, and I may have or may not have taken this talk in the direction you wanted me to take it. And I hope I don't do it wrong here. I really am hoping that you get something out of it and you like it. But hey, if I've done it all wrong, email me or text me later and complain, and I'll try to do it better. But I wanted to talk really about relapse, and to talk because the majority of patients that I see often are in and around Atlanta. They travel a distance to see me, and they often have another oncologist, their primary oncologist, who manages all their standard of care therapy. So oftentimes my patients are part of 5, sometimes 10 myeloma patients their oncologist manages, and that's all the myeloma patients their oncologist manages. And so a lot of times my patients are advocating for themselves. They're the one educating the staff, educating sometimes their own oncologist about myeloma. And so I wanted to give a talk today for. So when I was communicating with Rosalind over email, it was like, hey, listen, the folks that you're talking to are super educated. They know a lot of stuff. They are dialed into myeloma. So we're going to put that to the test today and see how dialed in you are. And I'm hoping I can be of use to you, because what I'm trying to do is have patients be advocates for themselves and have you advocate for patients, because in a situation where the majority of patients are in an office that's not familiar with myeloma, a patient is their own advocate in some ways, and a lot of it is challenging. A lot of it is data-driven, it's numbers, and it's trying to understand what kind of myeloma you have and what is the current status. And you'd think that that data would be super easy to come by, but if you didn't know already, that's sometimes a challenge. So let me talk to you a little bit more about that and see if I can be of assistance. All right, super basic. So those of you who are super sophisticated, just chill out for me. But basically on the left-hand side, can you all see this slide? Yeah? Okay, left-hand slide, you see a nice myeloma cell. Myeloma cells make these monoclonal proteins, and these essentially clog the kidneys and create kidney failure. Myeloma cells, shown here from a bone marrow biopsy in the lower part of the slide, infiltrate into your bone marrow and they chew at the bone marrow. These are like termites chewing at the cortex, the outer strong part of your, and this can create fractures and that literally basically chew the bone, the calcium part of the bone, and spit it back into the blood, causing high calcium levels and confusion. Also, these myeloma cells can fill up the bone marrow, increasing your risk for anemia, which is low number of red cells circulating in your body, and increasing your risk for infections by making other normal plasma cells less likely to have a life as your body is trying to push down on further production of plasma cells. All that's left are your myeloma cells, and this increases your risk for infection. Now, one of the things that's hard when talking about risk and is when the doctor says risk. That's not oftentimes when we say risk, it's not easily understood what the heck we're talking about, because every time we use it, sometimes we use the word risk differently. And so it's worth talking about. I'm going to talk about words like risk, stage, and control. And I'm going to try to define these for you because the way that average oncologists, average myeloma docs use them is complicated. And it's worth spending just a minute talking about. So if I say you have high risk MGUS, so come back in 3 months, there the word risk means you have a high likelihood of developing multiple myeloma, and I want to follow you appropriately. If I say you have high risk, if you're a myeloma patient, and I say you have high risk disease and will need to treat you with 3 or 4 drug cocktails, that means that you are less likely to respond to treatment and your myeloma will stay quiet a shorter amount of time than if you were low risk or so-called easier to treat. So risk there is all about how likely it is to you are to respond. And if I say your only lytic lesion or only hole in your skull, so your myeloma bone disease is low risk, there we're talking about risk in terms of risk of fracture, the likelihood these weight-bearing bones are going to go out on you. So risk sometimes is hard to interpret. Risk in the setting of myeloma, generally when we're dealing with multiple myeloma, low risk means you're more likely to have your treatment be effective against your myeloma cells. And these patients who have lower risk or easier to control myeloma live a longer period of time. And we're just basically choosing some year averages here a little bit to be consistent on the slide, but not consistent what's going to happen in the future, we hope. And then high-risk patients oftentimes are resistant to treatment. It's more difficult to control. They cycle through and become resistant to drug cocktails faster, and these patients have a shorter overall survival. So risk in the setting of myeloma often means how likely it is you're to respond to treatment. I know this is a long way from the original question of, hey, how do you talk about relapse? How do you know about relapse? But risk and control and stage all factor into that in ways that I promise to get back to you, but we're not there quite yet. Stage. So stage is very challenging. It's not a clinic goes by or a day on the inpatient service doesn't go by when I talk to myeloma patients. The myeloma patient says to me, hey doc, when are you going to stage my cancer again? And what they want to know is my cancer under control? Now, when a patient with lung cancer, colon cancer, breast cancer, prostate cancer, any normal cancer that's an epithelial lined organ, so not your liquid bone marrow, if we say you have early stage cancer, that usually means it's stage 1 or 2. It's isolated to a small part of the lung or prostate or colon or something. And the majority of patients, you can cut out that cancer and cure it. And standard lung, colon, prostate, if we say your cancer is metastatic, that means it's spread from outside its origin. Those same cells, let's say breast cancer cells, have now moved to the bones, and you have breast cancer that's metastatic to the bones. And that means you have breast cancer cells both in your breast and in your bones. And that's metastatic. Those patients who have metastatic breast, lung, colon, prostate cancer have a shorter survival. And here in the solid tumor setting, control and stage are synonyms. Now, that's not the case in myeloma. Myeloma, we generally so-called stage people at the time of diagnosis. And if you have easier to treat, you have stage 1. If you have harder to treat myeloma, you have stage 3. And if you have myeloma that doesn't fit into stage 1 or stage 2, like 60% of most newly diagnosed patients, you have stage 2. So stage 1, stage 2, stage 3 does not tell you where is the cancer. It tells you what kind of cancer you have. Easier to treat, harder to treat, or it doesn't fit into either one of those buckets, and that's stage 2. Stage and risk are different than control. Is your myeloma in control is generally a question that every myeloma patient and every doctor taking care of a myeloma patient should be asking every time they get together is the myeloma in control? And you can think of in control on the left-hand side, meaning that your myeloma is not making any new myeloma cells. So there are very few myeloma cells there. And in general, the kidneys are doing well, the bone marrow is doing well, the myeloma bone disease is not changing. This is where we all want myeloma patients to be. But as you go along towards the right-hand part of the slide, you get towards patients who are out of control. This has many new myeloma cells being made per second, per day. And these patients are high risk, fractures, anemia, and kidney failure. This is the so-called CRAB criteria that you see in newly diagnosed patients, but you also see it in relapse. And I think of this as basically jumping out of an airplane without a parachute. Uncontrolled myeloma is an emergency, and you want to do everything you can to get it under control. So, all right, now we're getting towards the part of the talk which is good for engineers and accountants. So this is your time. Engineers and accountants, come to the front because we're going to talk numbers. And numbers is what myeloma is all about in terms of understanding the status of your myeloma. So if you look on the horizontal axis, this is time. And if you look on the vertical axis, it is some numeric indication of your myeloma. And we're going to talk in detail about that in just a bit. It could be your immunoglobulins, it could be your light chains, it could be your monoclonal protein, whatever. But basically, for every patient who is gotten to be in a good spot on the bottom left-hand side and is getting ongoing, let's say, maintenance treatment, well, in general, you're asymptomatic if you don't have much myeloma percolating in your body. But right around a year and a half here, the patient is becoming slowly resistant to treatment. And right about 2.25 years, patient is accelerating in terms of how many myeloma cells are in the patient's body. And in the majority of these patients, as they rapidly accelerate into the end of what is on this chart, the 3rd year, that's when patients in this pink part on the right-hand side, this is when patients are high risk of developing a lot of symptoms. Here on the left, and up through the first year and first 2.25 years, patients do not have any symptoms. They're symptomatic. And I'm often talking to patients saying, listen, hey, don't you see your numbers? They're going up. We got to do something different, get your myeloma under control. And they give me a lot of, hey, I feel fine. I don't want to do anything. Please, no. But a lot of times this is when we start negotiating, talking about how the numbers give you an early indication before the patient develops fractures, anemia, and kidney failure, because we don't want you to be telling me, I don't want you as a patient to tell me, hey, your myeloma is not in control, because that means I have missed the boat. I want to be telling you, hey, I think this is about to cause you symptoms. Let's start treatment before you develop any symptoms and catch it so-called early. Now, patients who are low risk or easier to treat myeloma, they have lots of time here where their disease is becoming resistant, but it's becoming resistant pretty slowly. This might be a reasonable time to try a new and novel therapy, because that's when there's very little to risk, as patients don't have a lot of symptoms, but the numbers are getting worse. In this last quadrant, this is when things are rapidly increasing, and this is when you're highest risk of developing symptoms. So you see the numbers are whatever your best myeloma indicator is on the vertical side. As that rapidly shoots up, your risk of symptoms shoots up along with it. Now, if you're high risk versus low risk, everything is compressed. And so now you have very little time from, hey, I'm becoming resistant, to I am significantly symptomatic and we got to do everything we can to control this myeloma. So here, clinical trial is ideal whenever a patient is eligible to get treated, as these patients are harder to treat and less likely to get good control with any FDA-approved treatment we have currently. Okay, now we're getting a little bit even more into the details. This is when I start talking to my wife late at night about finances, and she starts getting very sleepy. So we're getting into more and more numbers. So hang on here for a little bit. Okay, so when you talk about numbers, you got to talk about what we're measuring here. This is super simple for some of you and still new stuff for others. So myeloma cells make antibodies or immune globulins. And sometimes they can make the whole thing. A complete antibody is the heavy chain here in whatever color this is. Looks kind of pinkish to me. And on the outside, it has these spoilers, and these are the light chains. So this heavy chain is the IgG, IgA predominantly, and the light chains are always kappa or lambda. So your complete antibody that most myeloma cells make, they make an IgG kappa, or they make an IgG lambda, IgA kappa, IgA lambda. That's the complete deal. So that's what these myeloma cells make. And when you think about it, normal plasma cells make a large sequence of very different antibodies. And myeloma plasma cells make the same antibody and the same light chain. And these antibodies and light chains are a little bit in circulation and go back and forth. These light chains kind of attach on and they come off. So there's some free light chains and there's the whole antibody all together. Your monoclonal spike is in general the total antibody, for instance, the total IgG, and then of that IgG, there's a monoclonal portion, which is in this graph, or in this figure here, it's an IgG kappa, let's say, or an IgG lambda. So it's a portion of the total IgG that we measure circulating in your blood is the monoclonal portion. And so you obviously, the total IgG, if it's 2,000 milligrams, the monoclonal portion of that might be 1,000 or 1,500 milligrams. It's a portion of that total IgG or IgA. So there are three ways to measure myeloma proteins. You can do an SPEP, or serum protein electrophoresis, and that measures the amount of your monoclonal protein. You can do a urine protein electrophoresis, which is very similar, except it uses urine rather than serum. And then there's the serum-free light chain. So you have your kappa and lambda light chains that you measure individually. And you can really only do this in the blood. All the methodology to do this in the urine has not been validated and not thought to be useful. So if you measure light chains directly in the urine, you're doing something wrong right now. So we really just want to see the monoclonal protein in the serum, occasionally the monoclonal protein in the urine, and the serum-free light chains. In truth, there's not a time when I look at the 24-hour urine in a myeloma patient now. We do a 24-hour urine when patients come as a new patient visit, and that's the last time I do it unless I'm required to do so for a clinical trial. We don't use 24-hour. We do occasionally use them in patients who have amyloidosis or were at risk of amyloidosis, but even now, we tend to use a spot random urine albumin and urine creatinine, and they take the place of these 24-hour urines in amyloid patients. But in myeloma patients, I don't use 24-hour urines anymore. It's no fun to bring your urine into clinic, and it's no fun to measure it either. So that's something that I don't do anymore, except on patients who it's required as part of their clinical trial. All right, so what kind of myeloma do you have? If you have an IgG kappa or an IgG lambda myeloma, then there are 3 numbers that you want to follow on your Excel spreadsheets. You want to have your IgG, you want to have your monoclonal, which is you get from your serum protein electrophoresis, and you want your serum, your involved light chain, which in this case is either your kappa light chain or your lambda light chain. I would always recommend get both. Get the kappa, get the lambda, and record that on your spreadsheet. You never know when they could become both useful. If you have an IgA myeloma, it's a little different. Most of the time, you just want 2 numbers, your IgA and your involved light chain, either your kappa or your lambda. The SPEP, or the serum protein electrophoresis, is often somewhat inaccurate, and that's not the case with IgG, and it's often the case with IgA. Now, sometimes if you're IgA, you just want to see if there is a monoclonal at all, and sometimes you can see that better with a SPEP. But most of the time, just following the total IgA is the best indicator of a patient with IgA kappa and IgA.
Premium American made.
I'm so sorry. Go ahead. No. Okay. Well, if anyone wants to interrupt me, just interrupt me and I'll shut up, and we'll take your questions. That I want this to people to get good value out of this. So
No, you're great. I think that was just background noise. Sorry about that.
okay, no worries. So anyway, for IgA myeloma, just follow the IgA and your involved light chain. Those are the 2 numbers. If you have a kappa light chain, so this is for patients who present and their serum immunoglobulins, their IgA and IgG are both low, but their kappa is way high and their lambda is way low. Then your number is just a kappa. Follow the kappa light chain, always grab the lambda at the same time, but in general, it's the kappa light chain that helps you. And guess what? If you have a lambda light chain, just follow the lambda light chain, grab the kappa at the same time. It's always helpful. Always compare the same units. And this, I will show you, will trip you up and me up all the time, is that they switch the units around on you left and right. They will often list the IgG as milligrams per deciliter. So if you have an IgG of 2,000 milligrams, and they'll list your monoclonal protein as 1.5. And you're like, 1.5, how's that monoclonal protein relate to my IgG? Well, if you convert it, 1.5 grams per deciliter is equal to 1,500 milligrams per deciliter. Then you can see how the total IgG at 2,000 milligrams makes, and a portion of that, 1,500 milligrams, is your monoclonal protein. And we're going to do some examples of that over the coming slides so you can see that in real life, because the whole reason figuring out the status of your myeloma is difficult is all about these numbers in these labs. And remember, just because you see a blood test say one thing and a urine test say the other, they got to be apples to apples. You want to compare them over time. So don't look at the light chains in your urine. Don't look at and compare them to light chains in your blood. In general, you won't be checking light chains in your urine, even though local oncologists can often click the box to say, oh, check the light chains in the urine. That's not going to be helpful. You either do urine protein electrophoresis on your urine, or you throw out the urine and just look at the blood. And in most myeloma patients, I don't do 24-hour urines repeatedly. Okay. This is the part of the talk that I have started doing more of, and I'm excited to tell you about, and excited to get your feedback on. So this is real life. I just took screenshots from a lab output here, and I didn't try to make it too realistic. Like after you 3 faxes and it's really squinty, really hard to read. This is directly from LabCorp, I think, and you can see the IgG here, the IgA, the IgM, and you can see their alpha, beta, gamma. I have no idea what alpha, beta, and gamma are, so please ignore them. And I mean that as somewhat tongue in cheek. I know what these things are, but I don't care about them. I don't use the albumin here, the alpha or the beta or the gamma. I never record these. I never follow them. I don't think you should either. The only thing that you want to follow here is the M spike, and that's the monoclonal protein. And you go over here and you see, 0.5 milligrams. And that's helpful because that tells you here that the IgA here, kappa, is 500 milligrams per deciliter. Now, here in what we'll go down the whole thing. You can see the kappa light chains at 36, lambda light chains 33.6, and then the ratio. So if you put all this in a little table here, you can see the IgG is 197, IgA is 323, and the monoclonal protein is 500 milligrams, and the total IgA is 323. Now you should complain at this point. You should say, hey, listen, the monoclonal IgA cannot be more than the total IgA. That doesn't make any sense. And you're right, it doesn't make any sense. And that's why in general, the SPEP is not as good in patients with monoclonal, with IgA myeloma, but it's reasonable. I just want you to have the data, but your IgA, if you're an IgA myeloma, is the value I want you to follow more closely. And here it's a kappa, so you're looking at your kappa light chains. So here you'd be following your IgA 323 and your kappa. Whatever they're measuring here in the monoclonal is not wrong, but it's only because these proteins in your blood kind of overlap, and it's hard to find, oh, these are the monoclonal proteins. And it's not that easy because of the test with IG. It's not that hard with IgG. It's very hard with IgA. Okay, let's do another one. This is a different patient, and you can see a different lab, and your job, if you think about it, is to fill out these little worksheet here on the right in this table. So you can see the total IgG is 1,037. That's always in milligrams per deciliter. You can see the IgA as well. You can look, they give you all this stuff here. None of it's helpful. I don't copy any of this down because I don't know what to do with this information. And then in the electrophoresis interpretation, they tell you what you want to see. No paraprotein detected by SPEP. That means their SPEP here is 0, none, no SPEP. Good, I can fill that row out. Immunofixation, where do I fill this out? Well, if you see what they say, no monoclonal immunoglobulin, and here they tell you serum immunofixation. That's the thing. The serum immunofixation is more sensitive than the serum protein electrophoresis. There will be many patients where you have a monoclonal protein that is not measurable, but is detectable by immunofixation. Here, the SPEP is 0 and the immunofixation is negative. So that's a more sensitive look for circulating. And in this patient, you can see their kappa and their lambda, and these are both milligrams per liter. These ratios are not quite the same as you can see on the free light assay, but they're very close. Okay, let's keep going. Another patient, yet another way to show this data. Here you see tucked in the total protein, the electrophoresis. Okay, I don't know what to do with any of this. The IgG, that's what I want to know. The IgA, the IgM. So here the IgG and IgA posted at 1,004 and 2,093. And here, immunoglobulin light chain. And you look at these normals. These normals look very different. Kappa is 176 to 443. Lambda is 91 to 240. Let me go back. This is a more appropriate range for kappa and lambda. This is still not quite the free light algorithm, but it's very close to the normal range. This is not the normal range. They're measuring the light chains in the blood, but they're using not free light. I don't know how to interpret that. I don't write that down. If I don't know how to interpret it, I don't write that down. So every time I get these light chains, I throw them out because these aren't the light chains, they're over here. But these normal range is not done by the free light assay. I don't know what to do with it. Abnormal protein band. This is the SPEP, serum protein electrophoresis 1.5. And what that means is of the total of the IgA here, 1,500 milligrams, that's the 1.5, is IgA kappa. Where do they tell you it's IgA kappa? They tuck it under here with an electrophoresis and immunofixation. They tell you there's an M spike that's measurable, and immunofixation tells you what it is. So that's how you figure out it's an IgA kappa. So of the total 2,093 milligrams, the IgA kappa is 1,500. Oh yeah, I often get this. My patients will bring this chart to me and say, all right, doc, how's my myeloma? And I'll say, I have no idea, because this is a serum protein electrophoresis. These are the alpha 1, alpha 2, beta, gamma, blah, blah, blah. And I do not know how to interpret any of this. This is not useful to you or me. I think this is getting close to the last one, so we're almost there. Bear with me. All right, here we have kappa and lambda light chains. These are the normal ranges for the free light assay: 3.3 to 9.4, 5.7 to 26, 0.26 to 1.65. I can read these things in my sleep. And here you see the kappa light chains are both elevated. And kappa and lambda are very close, but the light chain ratio is normal. Okay, now look, and here they tell you the serum protein electrophoresis. Here they're telling you immunofixation. Here you get protein, alpha, beta, blah, 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 blah. And then M spike not observed. That means it's 0. And that's all they give you, except the serum protein electrophoresis pattern appears unremarkable, not apparent. And you imagine that that's the immunofixation they did as a reflex here. Immunofixation is abbreviated IFE. So how do you fill up our table? Well, they don't give you serum immunoglobulins. You know that the serum protein electrophoresis is 0 because it's not observed. And the immunofixation, probably negative rather than the question marks, but it's not 100% clear if they reflexed it. You can see the kappa and the lambda are both elevated, and that's usually good for us. If you are thinking, is my myeloma out of control, and both the kappa and the lambda are elevated, you have a normal ratio, and that's almost always a good sign. So just because you have one number high, if the other number is also high and the ratio is normal, that usually is good for us. It means your myeloma is in control. All right, no, I lied. Second to last one. Now I think this is the last one. So again, kappa and lambda light chains, these are the correct free light ratios and normal reference range. Here they give you the IgG, IgA, IgM. Here they give you just the M spike, which is 1,000 milligrams per deciliter or 1 gram. Here they tell you the serum protein electrophoresis may represent monoclonal, it may be all this other shit you don't care about. The important, and they didn't send, may be confirmed with immunofixation. So in general, you would say the monoclonal protein spike is 1,000 milligrams. This is likely to be immunofixation positive, even though they didn't say they sent immunofixation. You can get the IgG and IgA into your table, and the kappa lambda comes from these top 2 rows and the ratio right here. So that's how to plug this in. All right, I have a couple more slides left and then you're done. You almost made it. That was a lot of heavy numbers. It's not very exciting, I know, but following myeloma is a numbers game. So when you're looking to follow myeloma labs, you're looking in general to follow the monoclonal protein in your serum, which is your SPEP, in your urine, which is your UPEP, or in the involved light chain. Now, we call it, if you hear your doctor say, oh, it's measurable, that means it's at a minimum level to say that if you see a change in this, it's significant. So if your serum protein electrophoresis or your monoclonal protein is greater than 500 milligrams, or your urine protein electrophoresis is greater than 200, or, and here's where it gets complicated, your involved free light chain, either your kappa or lambda, is greater than 100 milligrams, and the light chain ratio is abnormal. And think about this last case here, where actually 2 cases ago, your kappa was up, your lambda was up, but your light chain ratio is normal. You don't get points for that. You need your kappa up and your lambda below, or your lambda up and your kappa below. So that's what gets you to be so-called measurable. If you have this type of myeloma, where at the time, at the baseline, before you started treatment, whether you're newly diagnosed or you're at the first relapse, second relapse, third relapse, whatever it is, you can figure out, oh, am I measurable or not? If you are measurable, that means that blood tests are going to give you 90% of the information you need about the status of your myeloma. All you need is a blood test to figure out where things are. This helps you because often patients will ask, well, I saw this abnormality on my skeletal survey. Shouldn't we check up on it again? And on average, if you have measurable myeloma, you don't need to check up on it again because the blood tests are usually pretty accurate. Now, that's not quite the case in patients who are oligosecretory. We make these names to make it difficult to understand what the hell we're talking about. I don't know why we call it this way, but such is the way. This is the difference between having some myeloma protein that you can measure and having a lot of it. So if it's measurable, you have a good amount of protein. If it's oligosecretory, it's not much. It's not zero, but it's not much. So in this case, it's less than 500. It's less than 200 in the urine, or your involved free light chain is less than 100. And that's your baseline before you start treatment. If you do that, changes in your blood will tell you the status of your myeloma about 50% of the time. That means that the other 50% of the time, you could be missing things unless you do some cross-sectional imaging at the same time. Either a CAT scan, PET scan, MRI, something. So if you're oligosecretory, the incorporation of imaging into the overall follow-up process makes very good sense, and you definitely want to do that. The last group are the non-secretories. Now, these are a rare group, but they exist. And the longer you're at this myeloma game, the more your myeloma cells can't get it together to even make proteins anymore. So many myeloma patients become non-secretory during their treatment course. And this is when your myeloma can be raging active. You can have new lytic lesions. You can be anemic. You can go into kidney failure, but your kappa and lambda light chains are stone cold normal, and your immunoglobulins are all low. That means you're non-secretory. Hence, the blood tests are not worth a darn if you're trying to figure out the status of your myeloma. Here, you need to either use imaging tests or bone marrow biopsies or some combination of the two. It's really rough when patients have nothing to follow in their blood tests and nothing to follow by imaging. Then you're stuck doing lots of bone marrow biopsies, which, goodness, nobody wants. Thankfully, we're going to have some new technology called mass spectrometry, which is going to decrease further the number of patients who are truly non-secretory. Can't wait for that to be FDA approved and incorporated in all sorts of labs. Okay, I see a hand raised. C. Todd Kennedy, do you want to chat? Or no? No, okay.
No, we can wait till you're done. We can wait till you're done. Just
Okay.
You said a couple slides, just getting in the queue for when we're ready for Q&A. So continue.
No problem. No
Like
problem.
I said, they're dialed in. They're ready for you.
I bet. Okay, I think this might be the last or close to the last slide. And these are the rules. So if everything else needs to apply, there's a couple cardinal rules. So my favorite question is, hey doc, if my IgG gets to blank, does that mean blank or whatever? And in general, it's not the amount, it's always the rate of change and the direction of change. That's why, again, our favorite patients, engineers and accountants, they love to put the stuff in Excel and graph it. It goes up, it goes down, they get all excited, but that's super helpful because if you can see a pattern of the numbers going the wrong way, you got my attention. I'm very helpful. I'm very interested in this, and that's very helpful. Look at this patient here. Their IgG 1460, 1845, 1821. Their monoclonal 700, 800, 900. Their kappa light chain 23, 36, 42. All of these spots, if you just had two of these numbers or just had the monoclonals and not the light chains, just the light chains on the monoclonals, none of it really speaks to me like, oh, but all this information together, it looks like things are going the wrong way. And that's how I would talk to the patient and say, hey, things I think are beginning to go the wrong way. We need to start looking at your imaging tests, and we need to do some cross-sectional imaging to verify that your myeloma bone disease is not changing, because it looks like in the biochemical relapse, your myeloma is growing, but it may not be causing you symptoms yet. We got to start talking about seeing you more often, talking about what options are available to treat things, because what we're currently doing may not be working. So that's rule number one. Rule number one is that it's obvious when the heavy chains and the light chains go in the same direction. For a doctor, this is bad news if they both go up, and it's great news if they both go down. As an example, this patient has an IgG going from 700 to 1,000, SPEP 700 to 800, and kappa light chains 23 to 84. Any one of these data points alone may not be enough. They're not that big of a change. But if you put all those data points together, kappa light chains going up, SPEP going up, IgG going up, it seems pretty likely that this is not going the right way. So it's when everything goes together, you can make some conclusions more than you can if only one thing goes up. Light chains are super sensitive. That means they're not always that precise. So the changes in the light chains depend on their absolute value. Changes that are very similar are listed on this slide, but you can see the absolute value of the numbers are very different. 40 to 80, that's a difference of 40 milligrams per liter. That has the same kind of prognostic, or that's the same kind of control information that I would get if it went from 200 to 300. So the delta here is 100. The delta on the first row is 40. The delta on the last row is 400, but they all mean the same thing. And they mean the same thing because free lights dilute and dilute and dilute to get the absolute value and to report a number. And so what changes that are when your light chains are in the 1200s, you need to have a much bigger delta to mean the same thing as changes when you're 40 to 80. Okay. All right. Last point. Light chain progression, or meaning light chain, if patients are, again, I'm sorry about this. I was hoping to correct this on the slides, but I didn't get time. Light chain progression in oncology is always a bad word. Progression outside of oncology is always a good word. My kindergartner progressed to the first grade. That's positive, but your myeloma progressing means that it's it's resistant to its current treatment, and we need to do salvage. So I shouldn't have used the word progression here, and I'll try to fix that. But you can see here that the IgG went up a little bit, but not very much. The SPEP went up a very little bit, one notch, but kappa light chains going from 23 to 50 to 100, it's clear. And oftentimes you see changes in the light chains, and months later, the heavy chain, meaning the IgG, follows suit. Okay, I think, yes, that's it. I'm done. You made it. Strong work, all of you. For those of you who've remained awake during this talk, congratulations. What I love about these meetings is the free food. So anyway, I'll stop by sharing and happy to hear comments, questions, complaints, and feedback to do this better.
Oh, that was excellent, Dr. Hofmeister. And like you say, just an excellent tutoring in the numbers. And it is all about the numbers and knowing which numbers to watch and which numbers to talk to your doctor about, which helps guide us all. We have 2 questions so far. Bonnie had a question in the chat, and then Todd had his hand up. We have just about 8 minutes for questions, so I'll do my best to field as many as we can. Bonnie has a question about 24-hour urine questions. 203 milligrams protein and spilling polyclonal antibodies, serum labs normal, creatinine. Bonnie, why don't you unmute and just ask?
I can read the chat. I'm sorry.
Oh, you got it. What does this all mean? She's wondering.
Bonnie, great question. Every pathologist is lonely. They don't see live patients, and they're desperate to talk to you. They're desperate to tell you things. They want to communicate to you something. It's not a Hemingway novel. Just try to focus on what the hell are they saying. And if you have 203 milligrams of protein and you're spilling all this blankety blank, who cares? It's 203 milligrams is your total protein, and your urine protein electrophoresis is negative. So they want to communicate everything they see. They're desperate, but they're telling you there's no monoclonal protein, Bonnie, and that's usually good news.
Okay.
Can I answer the next one in the chat, or do we go by people? Or I'll let you control. I'm sorry.
No, that's great. We'll just go in order. So Todd, followed by Andrew, and then Nancy. Go ahead, Todd.
Doctor, that was terrific and really practical too. You covered like the perspective on staging, risk control. But as coaches, we hear patients say all the time, hey, I'm in complete remission, or I'm cancer-free. Can you give us perspective on, the information on the IMWG definition of complete response and your perspective on that? Because if the definition says in complete response, you can still have up to 5% plasma, to me, that doesn't mean you're cancer-free. That doesn't mean you're necessarily truly in complete response. So it's almost a disservice that gives people this false sense of security. And I'd just love to get your perspective on that. And would MRD information be helpful in giving a better assessment of the depth of your control?
You are correct. It's like I planted you here. I love it. All right. So here's the thing is that when I say to a patient, when I say to a myeloma patient, you're cancer-free, shoot me, because I'm obviously drunk. I never, ever say that to a myeloma patient because I don't know that. There's only 2 patients I've said, I don't want to see you anymore. And there was, after 20 years, they were serum immunofixation negative, and it had been 20 years since they had received any treatment. I couldn't justify continuing to pester them, and they wouldn't go. They kept coming back. So that patient, we kept seeing each other, and I love to chat with them. I don't say they're cancer-free because you got to prove it. Proof is in the pudding. When you say remission, I always say to patients, well, listen, you're in remission, which means I can't find any myeloma. So I don't distinguish when I talk to patients between stringent complete remission and complete remission, because I think that's cruel, and who the hell wants to get into that except my engineers and accountants. They do like to get into that. So I share it with them. But the rest of the normal people, they just want to know, do you see any myeloma protein in my blood, urine, or do you see any myeloma cells? Yes or no? And if I see any myeloma cells, meaning they're clonal in the urine, they're clonal in the bone marrow, I see a positive fish, I see a positive karyotype. If I see anything that says myeloma, I don't tell them they have remission. And I tell them I need all 3 of these things to be negative to reach remission. Yes, you're right that there's lots of stages, if you want to get into it, of the details of what is a remission. Is it complete remission, stringent complete remission with negative imaging, stringent complete remission with negative imaging and a negative minimal residual disease? That's all different levels of remission. So there's a few patients who I'm that successful. We've done all that testing, and I'm delighted to talk with them about it. But for most patients, all those different levels of remission don't really help you a ton. They're usually like, okay, this is what I know, that's good or bad, and how does this affect what we do going forward?
And thanks for clarifying on the light chain ratio too, because I'm Kappa light chain, and I have very, very low lambda, so I'll never have a normal ratio. But
Well
and
said.
that throws people off, I think, a lot of times as well. So thanks for,
Yes, it does.
thank you.
Thank you. Andrew, go ahead with your.
Thank you. And Doctor, thank you very much for all this great information. What do you look at to determine whether a patient has gone from secretory to non-secretory? And would you recommend that a patient who appears to have been in remission based on blood work for a long period of time still get imaging?
Right, great question. So number one, if you go from non-secretory to non-secretory, that means your myeloma is active, meaning I have some reason to think that you have active myeloma, either by bone marrow biopsy or imaging test, and your numbers are negative or normal. So your immunoglobulins are either normal or low, your monoclonal protein is negative by immunofixation, and your serum free light chain ratio and serum free light chains are essentially normal. That's non-secretory. I call you non-secretory when I know you're active and I know you're not making any protein. And for answer to your second question, I don't like doing imaging for no purpose. So I will not image you unless you're on a clinical trial, I'm being forced to image you at a set time point, or I'm imaging you because I'm worried about your myeloma. I'm not going to do PET scans annually just for the fun of it. So I only image if there's a reason for me to think it's going to be positive.
I guess my point was, if your numbers don't show anything, in other words, you don't have an M spike and your IgG and your light chains all look normal, how do you know that you have not moved to non-secretory? Would it be because you have bone pain or anemia, or what would it be?
Yeah, some evidence of disease. Correct.
Thank you.
Okay, we have 1 minute left. Nancy, go ahead with your question.
Yes, my husband has been on DARA for 3.5 years, and that seems to create some difficulties with the M protein test. Up north, they're sending his test to Mayo Clinic, and all that comes back is it gives a number, which I assume includes the DARA protein, and then it says that the M protein is very low. It doesn't give a number. Down here in Florida, they give us a number sometimes which seems to include the DARA protein. So it's a little confusing between different laboratories.
I share your confusion. And, on average, the Mayo Clinic laboratory is the reference laboratory, the one in Rochester. So they're going to do things extraordinarily well there. And, so it's a question that, daratumumab is an IgG kappa monoclonal protein. It happens to be therapeutic, but it's still a monoclonal protein that you're injecting. So it is going to be circulating around there for myeloma patients whose myeloma makes IgG kappa, and you're getting daratumumab, which is an IgG kappa monoclonal protein. Well, shit, how do you differentiate the two? There are ways to differentiate, but they're expensive and not done necessarily regularly. So sometimes, while it can be done, usually it just means for you that your myeloma is under good control if they can't tell the difference.
Okay, one other question. Ever since my husband has been getting the COVID immunizations, his IgA has been trending up, but the M protein has been staying the same, and the kappa has been fluctuating within a range 12 to 36. Can we be confident that that IgA that's going up is polyclonal?
Great question. Does he have IgA myeloma?
IgA kappa.
Okay, so you're in that awful gray area where your IgA may be going up, but the monoclonal is 0, and you and I don't know. Shit. And there's nothing perfect during that time. Sometimes you can do some imaging tests if the patient has complaints and maybe they have oligosecretory myeloma where it's active and they just don't, their IgA is going up, but it's not enough to show up in the serum protein electrophoresis. It sucks. I hope instead that on the positive side, I'm hoping that his myeloma is under control and his IgA is related, the slight IgA increase is related to COVID, sunspots, eating more gluten, God knows what. But I hope it's not his myeloma.
Okay. Oh, the hardest part of this is always stopping the Q&A. And I know there's lots of questions, and Dr. Hofmeister, are you not only brilliant, you are a lot of fun. And I can't thank you enough. This was a phenomenal presentation, and your time is so valuable, and we truly appreciate you sharing it with us today. Thank you so much.
Absolutely. Good luck all. I'll try to take a shot at some of the questions through the while I'm getting the hook. Also, Rosalind has a link to all my slides today. She can share it with you. And if you want to provide feedback, complain about them, tell me how to do it better, don't hold back. Thank you so much for your time, and good luck to you all. Thanks for all you do.
Thank you so much. That was phenomenal. Well, thanks for your questions. I'm sorry we couldn't get to them all. We are excited for our next speaker, and she has a hard stop. So Rebekah, thanks for your patience with us. I'm really excited to turn the time over to Rebekah Tobin. She's the West Coast Patient Advocacy Liaison with Takeda, and she's joining us today to share some highly valuable resources about navigating life with myeloma, as well as infection risks and the importance of vaccine. So I'll let her provide any additional introduction that you'd like, and welcome, Rebekah.
Thank you so much, Rosalind. And I don't know how I'm going to follow that. I mean, what an extraordinary speaker. And that was just amazing, Dr. Hofmeister. I took notes. I was like writing notes down because we too have a presentation on lab values. So I learned a lot. So thank you for that. And thank you all for being here. I see some familiar faces, which is always fun. Hi, yep, there's Todd and Diane, and I know several other myeloma coaches, and I'm so grateful for this program because I think that it just provides such value for people living with multiple myeloma. So a big round of applause for Rosalind and all that she does to keep the program up and running. And I'm just going to briefly share a couple of resources that we have available. We do have presentations. I know some of you have seen some of the presentations that we have to offer. And because we're not allowed to share those presentations, we thought that we would stick to focusing on some PDFs that we can share and that you all can utilize in your coaching sessions when you have them with your people. So let me pull up the first one. What's this? Where did it go? Of course I can't find, oh, here we go. Okay, can everybody see this?
Yes.
No, I'm getting head nods, so that's always a good sign. So this is the first one. We're going to go through this one. We're not obviously going to go through all 36 pages because I think you would all be asleep at that point and you stayed awake through that brilliant presentation that you just had. So this is our multiple myeloma resource navigator for people living with multiple myeloma, their care partners, your family, your tribe. It really is a one-stop shop for all things resources related to multiple myeloma. Again, we do offer this in a presentation mode, but for you all, you have this resource available for you, and it can be provided via email, or you can actually order a hard copy. And I'll make sure that Rosalind has my contact information, as I would be the one that you would order it through. It's beautiful when you get it in a hard copy. And I also think that it would be beneficial to have during those coaching sessions. So as you can see, we have these different areas of focus, or what I call buttons, starting with getting started with multiple myeloma. We then move into resources with connecting with others. And we know that that's all very important, especially during the times of the pandemic when we've all been apart. We then move into resources during treatment, which again, also very important, being that myeloma is now being treated more like a chronic condition. And so resources related to treatment is important for people wherever they are during their journey. Financial and legal support resources. This is huge, and I'm actually going to give credit where credit is due. Todd gave me the phrase, and I do repeat this every time I give this presentation, never leave money on the table. So oftentimes people think that maybe they make too much money or not enough money and they're not going to qualify for certain financial resources. And this part of the guide really goes in depth into all of the many financial resources that are available to you as people living with multiple myeloma. So again, a great coaching point when it comes to coaching your people. Living well after a myeloma diagnosis moves in more into like health and wellness and making sure that you're developing those skills to stay healthy. And then as you can see, you move down here a little bit, we have resources for family and friends, right? Because this diagnosis affects everybody. It affects the whole ecosystem when it comes to our care partner and our family and our friends and our tribe. So we want to make sure that we provide resources for those people as well. And I'm going to skip ahead here. This is just some general information and introduction. What I think is really amazing about this resource is that you can meet your people where they are when it comes to your coaching sessions and utilizing this particular resource. So say you start talking and you uncover that the person that you're working with is really struggling with their copay. You can look at all of these organizations, which are featured on the left-hand side, go over to the part where it says financial and legal resources and see which ones have that check mark. And then you can go directly to those resources where they are in the guide. So again, it really is a great guide in terms of meeting people where they are and helping them uncover some of the barriers that they may be facing, whether it's financial or just getting started. If they're newly diagnosed, that's, you know, how overwhelming that is. And it's a lot to go through. So there are checklists for all of the resources. I'm going to skip ahead and just show you some of the financial and legal resources. So again, it goes through many organizations and they all have help when it comes to financial and legal resources. So if your patient, if the person that you're working with is struggling maybe with Medicare and Medicaid, we've got HealthWell Foundation that helps specifically with those people. And it really does take a deeper dive into all of these resources. So again, I'm not going to go too much into it because it is 36 pages. And just a reminder, we can email this to you if that's easier, if you're meeting with the person virtually and you can go through it online, or if you are able to meet in person and you do want a hard copy for both you and the person that you're coaching, I'm more than happy to order that and it's shipped directly to your home. So now we're going to switch to infections and vaccines. So let's get back up here. These were at the beginning when I had them pulled up. So infection risk and the importance of vaccination. This is obviously a very hot topic in the era of the pandemic that we are currently all still living in. And also, I think it's important to note that this particular brochure doesn't just focus on COVID. It goes into all of those infections and vaccinations that we want to make sure people living with multiple myeloma are staying on top of, such as flu, pneumonia, shingles, and then obviously the COVID-19 vaccine. And it starts with a brief overview in terms of explaining to the people that you're coaching, you know, why are you at an even greater risk than the general population? And honestly, even the general population of cancer patients than the average person in terms of developing infections. And it talks about myelosuppression, risk factors, all of the things. So I think that that's a good talking point. We then go into some specific definitions in terms of what the heck are vaccines, how do they work, what they do and do not do, how vaccines work synergistically with our own immune system to make it stronger, and then also some specific terms when it comes to vaccinations and infections that are also important to note. We then move into who and who isn't recommended to get vaccinations. I think that that's always important, especially if it's a person who maybe is getting ready for the stem cell transplant, kind of going over those guidelines for post. They may have some questions in terms of vaccinations. And this is the mic drop moment when it comes to this particular resource. It has a place where your people can keep track of all of those questions that they have regarding vaccinations. And then also, as you can see over here on the right-hand side, if they are recommended to get the flu vaccine or the pneumonia vaccine, they can put the dates. And then you see we have the 3 dates here for the COVID-19. And this is really helpful, especially with all of the confusion in terms of the primary shot series for people who are immunocompromised and how that's changed. And just to have a place to keep track of all of these immunizations. I mean, I went through travel nursing several years ago and they asked me for my immunizations and I was like, I have no idea where that information is. So to have a page where they can keep all of that information, I think is hugely helpful. And then we move into some additional resources and guidelines when it comes to what does the CDC say, what does the NCCN say in terms of these vaccinations for people who are immunocompromised. And then last but certainly not least, some additional online resources that you can use in terms of if they have any questions or you have any questions regarding vaccinations and infection risk for people living with multiple myeloma, such as the CDC, IMF, Myeloma Crowd, which you are all very familiar with, and et cetera. So those are the two resources that we thought we would cover from a Takeda Patient Advocacy Liaison perspective. Again, because we can't share the presentations, but we can share these brochures. We do also have a lab brochure that I didn't feature because I didn't think I would have time, but that goes into some of the information that Dr. Hofmeister just covered and also gives people a place where they can keep track of all of their labs if they're old school like me and they like to use pen and piece of paper. So I'm going to stop sharing my screen here and see if there are any questions for me.
Well, and Rebekah, so I require Rebekah to pack a lot into a little bit of time, which she did, and that was phenomenal. And maybe at our call in September, we could take a look at the lab handout that you have. That would be a great time we could do that. Well, Rebekah has a hard stop, but there's a couple of minutes. Any questions for her? Nancy, is your hand up for Rebekah, or is that still up from? Okay. I want to make sure I'm not missing anyone. Well,
I feel bad. I stole time from the questions before.
No, you didn't. No, you didn't. This was spot on and keeping right in schedule. And I see Dr. Hofmeister is answering questions in the chat. So feel free if you had a question in the chat to look there. But I just am grateful for Rebekah's time and sharing these resources. And as mentioned, now those that you sent me, Rebekah, could I forward those on and share those?
Please, absolutely.
Okay.
Yep, I see.
So I have both.
Yeah,
go ahead.
Victoria had a question about how to get them.
Oh, yes. Go ahead, Victoria. Why don't you could unmute and ask that.
Oh, yeah. I just didn't know how we could get that handout she just had presented. That looked awesome.
Yes, I
And
have
you
both
got
of those. I have both of those, and I will send them out to everyone, to all coaches. And so you can watch for
you.
that. I'll send that out.
Perfect.
So you can have it. It's a great resource.
Rebekah spoke at our SoCal meeting in November and shared her full resource. And we had one caregiver that watched that, and he then followed up afterwards. And I'm trying to remember the numbers, but the amount of money, the financial burden that he had going in, and the relief that the information that Rebekah provided in that pamphlet saved him tens of thousands of dollars every month. I mean, he's on cloud 9 as a result of reading through what Rebekah shared and then following up on it. It was really helpful.
What a great success story. And it is such a conclusive list with all of those resources. It's like a one-stop shop, really, for us to be able to share and use and to help people, that everyone that we come in contact with. Any other questions for Rebekah? Thank you so much.
Oh, thank you. Thank you for having me. I love myeloma coaches. Y'all are amazing. Thank you for all that you do.
We're excited to see you. Thanks for joining us and look forward to seeing you again soon.
Okay, bye.
Okay. Take care. Bye-bye.
Bye.
Well, we have a jam-packed day and it's not over yet. So if you need to stretch, whatever you need to do, I'm excited. Last but not least, we have the privilege to hear from our fellow coach, Vicki Jones. And it was a nice segue from Dr. Hofmeister with what Vicki's going to talk to you about. She's taken on a new role, leading out a new Myeloma Crowd community group. And she's going to share a little bit about that with us today. And I'll turn the mic to you, Vicki, and just let me know when you want me to pull up your slides.
Okay, thank you, Roz. I see that we're already losing participants. Don't go away. I need you, and I promise I'm going to be brief. I would be one of the ones going, aren't we finished yet? I want you to know, it was amazing that Dr. Meister talked about non-secretory myeloma, because you never hear about that. And that is what I'm talking about too, because that's what our new group is. A lot of you already know that last August, right after the coach summit, I found out that I'm a non-secretor. After 17 years of being IgA lambda, doing blood tests just about every month for 17 years. My IgA plummeted down to 27 after it had been like 300 and something all the time. My M spike that had been 0.1 or 0.2 was 0, and there was no reason for it. And so I asked for a bone marrow biopsy. There was myeloma there, 80% plasma cells. And so I had become a non-secretor. That question that we had during Dr. Hofmeister's talk about doing the imaging to look for, to make sure that you haven't become a non-secretor. I had no symptoms. I felt great. There was no reason to think that my bone marrow had such a high percentage, but I just felt like it couldn't be right. So I asked for that. It turns out imaging is actually used even more than bone marrow biopsies to keep track of your non-secretory myeloma. Anyway, I felt lost and alone when I found this out. And I never ask people for help. That's just not me. But I tried to find other people with non-secretory myeloma, and I couldn't. It's like looking for a needle in a haystack. There's like 120,000 people living with myeloma in the United States. 3% of people are non-secretors. So that would be 3,600 people. How am I going to find them? So I reached out to the best person I could have, Roz. And Roz, she didn't know how to help. She didn't know anybody that had it either. I had tried the twin machine. There was no way for that specific search to happen for non-secretors. But eventually, and Roz never forgot, every time I talked to her, she would say, I haven't forgotten, Vicki. And eventually they used their database on HealthTree to find, I got an email from Roz, we found 200 and something non-secretors, and I was floored. And so that is when Audrey got involved and we started our group. So if you want to start that first slide, Roz, the group already has 105 members. Wow, I was so impressed. And the people that have signed on that are interested in this subject have been so excited about it because they were like me. They felt lost and alone too, trying to find other people that have this particular factor. And so the next slide, what is non-secretory? And how do you say non-secretory?
There we go. Sorry.
Well, that was one of the things. My grandma told me always to make sure I pronounce things properly. And so I looked it up here and there and everywhere. And it was pronounced many different ways, wherever you looked for it on the web. Even I had a consultation with Dr. Fonseca, and he called it non-secretory. Both are correct, it turns out. So if you call it non-secretory or non-secretory, either one is fine. Okay, Grandma? And what it means, you learn from Dr. Hofmeister what it means. Whoops.
I'm sorry. This is technical difficulty on my end. I'm so sorry, Vicki. Let me work on that.
It means that your myeloma clones do not come out of your bone marrow into your blood, so they can't tell with a blood test anymore if your myeloma is active. So I thought you might like to know real quick that there are 4 types of non-secretors. And the first one you've already heard about today, the oligosecretories. And it's interesting because everything I read about said that if you're an oligosecretor, you're a light chain myeloma patient. But that's not the way Dr. Hofmeister presented that. So now I have to do some more studying. Literally everything I've read says that the free light assay has, the next one, Roz.
Oh my, oh,
No, two back.
sorry.
There we go. Because of the advent of the free light test, a lot of people now they're still non-secretors, but there's a way to follow their myeloma with that free light test. So their oligosecretors can be followed with a free light test according to the literature that I've read. The second type is non-producers. And there's another slide for that one. Non-producers, it tells me the myeloma, there are no myeloma clones in the blood or the marrow or anywhere. So I don't get it, because then how do they know you have myeloma? I don't know. I'm learning. These are some things that we're going to have to tackle in the group. And the third type is the true non-secretors. That's what I am. I have no, thank you so much for doing this, Roz, because that would be me. I
don't know why you're thanking me. I cannot get this to be consistent with how it's progressing. I am so sorry.
The true non-secretors are the ones that do have evidence of myeloma in their bone marrow, like me, and it's just not in the blood. And then the fourth type is a false non-secretor. And the false non-secretor doesn't have it in their blood or their bone marrow, but myeloma keeps showing up in different parts of their body. And so I've been, of course, studying on Health Tree University, and there's something on there called macrofocal myeloma that's talked about, and that has no evidence in your bone marrow of myeloma, but myeloma all over your body as well. So I'm thinking maybe that's false non-secretory. I was trying to ask Dr. Hofmeister, but we ran out of time. So there's so much to learn. And the people with non-secretory myeloma are thrilled to have this going on. We've already had 2 wonderful meetings. Our next meeting is how to use Health Tree Cure Hub to further non-secretory research. This is really important because people that are non-secretors at diagnosis have a terrible time getting diagnosed. And sometimes their disease is really out of control before they find out that it is myeloma. And then in May, we have Dr. Sasha Tuchman. I hope I'm saying that right. And he's going to talk about myeloma trials, because rarely are non-secretors accepted into trials. And hopefully there will be some that will be helpful to us. And then in June, Dr. Berenson is going to talk about his soluble BCMA test. This test has been around forever, and I don't know why it hasn't been approved for wide usage, because it's amazing. It measures the amount of BCMA in your blood, and maybe for non-secretors could mean not so many bone marrow biopsies. So those are the things coming up. And I just want to ask you guys to be aware of this when you're coaching people. If you run across somebody that's a non-secretory, let them know about this group and let us know about the person so we can reach out to them. And also just be aware that, like me, it happens in people that are highly treated, have had myeloma for years, that they can change into non-secretors. So be aware of that, both for yourselves and for the people that you coach. And I just want to thank you for your time. I hope you were listening.
Oh, they were. There's some questions, Vicki.
Okay.
Well, Bonnie is wondering if they're not non-secretory, do they need to join the chapter to see those upcoming presentations?
Yes, I meant to say that you are welcome to join. Sometimes the subjects that we talk about are for comment by the people that are non-secretors, but you're welcome to join. And unless we say otherwise, you're welcome to take part. Absolutely, we encourage it.
Okay. Now, Mary has another question, and Mary, feel free to unmute. Wondering if non-secretory typically occurs in blood types A, B, or AB in relation to myeloma. I don't know the answer to that. I'm not sure in your research, Vicki, what you've come
I
across.
haven't seen anything in that regard. It would be interesting if you come across anything, Mary, let me know.
It's just something I saw, and I'm wondering, myeloma messes with us completely, so it can change as we breathe, and then tomorrow it's something else. So is non-secretory something that we all should be aware of? Is it something that we can migrate or mutate to?
It is, but I wouldn't be too concerned about it because it doesn't happen that often. But I get the impression from what I'm learning that the longer you're fighting myeloma, the more likely it is to happen. So yeah, you should be aware of it. And just, if your numbers all of a sudden plummet like mine did, don't think it's wonderful until you check it out.
Thanks.
No, that's great. And Vicki, thank you so much. She had those beautiful slides, and I'm so sorry that I botched the presentation of those. But I'm just grateful for Vicki being willing to share her times sharing about this, because it is so helpful for awareness for yourselves, for those that you're talking to just be aware, just learning from Vicki. Thank you, Vicki, for being willing to share your experience with us, because that's so helpful to be able to hear what and how this occurred for Vicki, to know, to be aware of yourselves, or if you have people sharing that with you as well. And it really is so commendable for her to put all of her energy and effort into this chapter to gather other people together, because it is such a small cohort, a small group, right? And so supporting one another really can make a difference. It's just another testament of the benefits of that support. So thank you, Vicki. I really admire you for putting your time and effort into helping others in yet another avenue. So thank you.
Thank you.
Any other questions for Vicki? This was Lou. Go ahead.
Okay, I had to unmute. I just wanted to let Vicki know that a person I was beginning to coach a few months ago found out she was non-secretory. And as soon as I saw the notice through the health tree emails about the new group, I let her know, and she was so excited and so thankful. So I gave her the link so that she could, she's registered as a patient through health trees. So she was so excited. So I just wanted to let you know that as soon as I saw that and I heard that she was non-secretory, I thought, oh, she needs to check this out. So thank you.
Thank you for doing that. Was it Denise?
Yes.
Yeah, thank you. I appreciate it. And she is really happy, and
good.
We're so happy to have her.
Good.
Right. Well, it seemed that everyone, the feedback I got, Vicki, was just after that first meeting, everyone was just so grateful, right, to have found one another and the group. So thank you, Lou, for referring. And this has just been a jam-packed afternoon, and we do fit a lot into a little bit of time. So I know it was a lot of information, but I hope you found it helpful. I have a to-do list and things that I'll be sending out to you. The video is recorded. It'll take me a little bit of time to clean it up, but then I'll send out the video to everyone, as well as Dr. Hofmeister was so gracious to share his slides. So I'll get those and share those, as well as the resources from Takeda. Don, did you have a question as we round?
Just a quick comment. Dr. Hofmeister was talking about lab values. And one of the things that I found on my light chains when I first was diagnosed, the labs units were milligrams per liter, which is a larger number. And then a couple of years ago, they switched to milligrams per deciliter. And in the one slide that he showed, that he said, the numbers were lower, and he, didn't use those. Those were in milligrams per deciliter. One of the things that I found is in CureHub, when you enter your information, or if you download it, it recognizes, or if you put it in manually, you've got to select the right units. Units are, I'm one of those engineers, so units are important.
Mhm.
CureHub automatically unitizes it, and you get a consistent number. So it's another reason to encourage patients to use CureHub, because if they're getting a lot of data from a lot of different labs, it puts it in one place and in the right units that you can look at those trends better. So I just offer that for the coaches to keep pushing the folks to use CureHub.
Thank you, Dawn. That is a great resource, like you said, and to have the consistency to be able to track is huge. Thanks for pointing that out. Well, I learned so much from all of you. Thank you so much for joining today. I'm so grateful to have spent this time with you. And if you have any questions or things that I'm missing, let me know, and look for those resources in your inbox coming soon. Take care. Have a good day. Bye-bye.
Thanks, Roz.
Thank you, Roz.